Hello, this is Stephen Holloway. This is Nursing 203. We're discussing Module A, congenital heart defects. The defect we're going to discuss now is called patent ductus arteriosus. If you remember from your fetal circulation, the ductus arteriosus is a connection between the pulmonary artery and the aorta. This is to allow blood that actually moves into the right atrium and the right ventricle to be shunted back into the systemic circulation instead of being pumped through the lungs. In fetal circulations, there's such high pulmonary vascular resistance that it's very difficult for blood to get through there, so the blood is actually shunted back into the aorta. The ductus arteriosus typically begins to close as soon as the child is born and should be closed within 12 to 24 hours after the child is born. It can close. It can take 2 to 3 weeks for it to close, but typically it's closing very early in these children. Now, the instance of the PDA, or patent ductus arteriosus, as we see it in about 5 to 10%. It composes about 5 to 10% of all the congenital heart defects. It can be isolated, meaning that's the only defect, or it can be there with other defects. We do see the risk of a patent ductus arteriosus going up with our premature births. A child who weighs less than 1,700 grams has a 45% chance of having a patent ductus arteriosus. If the child weighs less than 1,000 grams, there's 80% chance that it will remain open. We do see this 2 times more often in girls than boys, and we do see an increased instance of it with children born in high altitudes. Don't really understand the physiology on that, but do know that that's one of the things that you can see. Again, we talked about this begins to close when the baby's born and takes their first breath, and it can take a couple of 3 months for it to actually close completely. The pathophysiology related to this, again, we talked about that it is a conduit between the aorta and the pulmonary artery, and when that child is born and the resistance goes down in the lungs, we see a shunt. We actually see blood going from the high pressure aorta here down through the PDA back into the pulmonary artery. Once it gets back into the pulmonary artery, then it then goes back to the lungs and then comes back into the atrium. Now, what can happen is, because of this increased pressure here, it's taking it harder for the right atrium and the right ventricle to work. So we can actually see problems with that right ventricular hypertrophy because of the increased pressure in this area for the blood coming back through. It makes it more difficult for the right ventricle to pump against that. So we can see some right ventricular hypertrophy if this goes on for long periods of time. We do see an increase in the pulmonary circulation because there's extra blood coming in and going back to the pulmonary circulation that shouldn't be, so there's extra blood going through. This is an acyanotic type defect, so the child doesn't have any cyanosis. And the reason is, again, because we're mixing oxygenated blood back in with the unoxygenated blood that's just returning back to the lungs. Again, this is normal in fetal circulation, but should begin to close once the child is born. If it doesn't close, the ductus arteriosus doesn't close, then you'll hear the term patent ductus arteriosus. And the degree of shunting here and the symptomology is going to depend on how large it is. They can partially close or they can be fully open. Clinical manifestations that you may see with these children, a small PDA, typically the children are asymptomatic. It may not even be picked up on the initial exam in the nursery, or maybe even when this child comes in for their 2-week checkup. The large PDAs, though, typically will be found because there's a murmur, kind of a short systolic in newborns, and then if you're following these children up later for these PDAs, it's more of a continuous type murmur that's heard under the left clavicle in the older children. If these children have a very large PDA, we can begin to see signs and symptoms of congestive heart failure. If we are seeing signs and symptoms of congestive heart failure, we then need to begin treatment process for these children and see what we can do for that. Diagnostics, typically, chest x-ray is really only going to show if we have hypertrophy of the ventricle or we have fluid building up into the pulmonary system, causing some pulmonary edema, some fluid buildup there. The echo is actually what's going to show more. It will show that opening and show the flow of blood going from one area that's not supposed to be to another area. The way to see exactly how large it is of course with a cardiac catheterization, where you can actually view it with a dye going through the area. But typically that's not necessary to be done. So how do we treat these? How do we treat the PDA? It depends on whether it's a newborn, full-term newborn, or if it's a premature newborn. The preemies, we give a medication called indomethacin. Indomethacin is a non-steroidal anti-inflammatory drug, and it's given IV to actually help close. Indomethacin is a prostaglandin inhibitor. Prostaglandins actually help keep that ductus arteriosus open. So we want it to close. So in these premature infants, we'll give them an IV of an NSAID called indomethacin. There's some studies out there actually looking at Motrin, IV Motrin to be given and seeing if it's effective. Studies are promising right now. The thing with using the IV Motrin is it has less side effects than the indomethacin. So you may see that being used in the future for that. Now, do understand that the indomethacin is not effective in full-term infants. Let me say that again. Indomethacin is not effective in full-term infants. It's only used in premature infants. Treatment in full-term infants basically would be surgery if it's necessary. If the child is asymptomatic, probably just going to watch and wait. These may close. If the child is asymptomatic and it has not closed, typically before the age of 5 years old, they will take this child in and close that. Now, if the child is having symptoms, then they go in and do a surgical ligation of the area. Now, the surgical ligation basically involves doing a thoracotomy type incision, and they can go in and actually oversew it so it's blocked. They can actually burn it. There are several different methods that they'll use actually to stop that area. The other thing they can do is they can do interventional cardiac catheterization and go up there and put coils in there. They're Dacron coated stainless steel coils, and they basically go in and block it. It creates a blockage in there, and eventually that blockage will totally go away. But again, if it is a very large defect, surgical ligation is the treatment of choice for this PDA process. And of course, anytime you do surgery, there are complications that can occur. Of course, when you're going into the chest and opening the lungs, there's always a problem that can occur with the chest tubes, those type things, because it is a thoracotomy type incision going in. But you can also have injury to the laryngeal nerve, which will cause hoarseness in these children. Can be temporary, can be permanent. That's one of the things you don't know right at the early onset. You can also have injury to the left phrenic nerve, which causes paralysis of the left hemidiaphragm. Both of these are rare complications, but that's some of the things the physician has to explain to the parents as they're going in. Typically, these children who have these either the surgical ligation or have the coils placed live a normal, healthy life. There's really not any big problems. They go on with their life just like any other child. If it's that's the only problem, is an isolated PDA. Again, remember, they can occur in combination with other problems. If these children go without treatment, again, here in the U.S. we see that very rarely, but maybe in the third world countries you might see it. But without treatment, these children begin to develop heart failure, pulmonary vascular disease, and can develop endocarditis. Really get a big change in that pulmonary vasculature, begin to get pulmonary hypertension. So it is pretty bad. One of the things that one of the books I looked at talked about, if these children have a patent ductus arteriosus before the surgical ligation, they need to have prophylactic antibiotics before dental work. Once it's surgically ligated, that can stop. Did not see where it said if they had coils, but I imagine if the coils are there, they're going to go ahead and do the prophylactic antibiotics before dental work. I won't say that with 100% surety, but something that to look for and ask about with these children. Okay, so this is just kind of a review of some of the different things we've talked about. We've talked about the increased pulmonary blood flow, the left to right shunts in these children, those where your patent ductus arteriosus, which we've just discussed, atrial septal defects, and ventricular septal defects. Typically these children are fatigued, they have a positive murmur, they're at increased risk of endocarditis, increased risk of congestive heart failure, and typically we'll see growth retardation with these children. I love what it says. It says, I'm not blue, just tired all the time. And the blue referring to, these are acyanotic. These children do not have cyanosis with these processes. So that's what they're talking about with that I'm not blue section. That concludes the lecture on patent ductus arteriosus. Have a good day.